Mr. Tofir, Dr. Tofir.
You can start, Doctor.
Good evening, colleagues, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe to this webinar. This webinar is semi-accredited and is conducted in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who always helps us. Well, today the title is Sleep Disorders in Children. We have eminent speaker and panelists. In a short while, I'll be introducing them. Well, as usual, we have a question. These two gentlemen are the same person. Now I'd like to request the viewers to tell us who is this gentleman and what is his contribution to the field of pediatrics. You have few minutes time. You can write your answer in Q&A box. The best and correct answer will be announced and Dr. Tawfiq will consider a prize. Beautiful Dubai, view of Sheikh Zayed Road, Atlantis Hotel, view of Burj Al Arab background, Burj Khalifa, and beautiful Dubai. Those who have not seen, please come and visit this beautiful city. Well, on behalf of members of Dubai Pediatric Club, here they are seen in the 9th annual conference and DPC symposium. And on behalf of the organizing committee, I would like to welcome once again all viewers and the organizing committee, myself, Dr. Joshi, past president, Dr. Kalpana Sengupta, the secretary of the club, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Muhammad Amir Tolemat, Dr. Ayman Jundi, Dr. Rafia Owera, Dr. Srinivas Pandari, Dr. Leila Bahri, and Dr. Khalid Rashid. Well, as I said, today we have eminent speaker and panelists. Our speaker is Dr. Muhammad Nami from Canadian University. Of course, in a short while, I'll be introducing them in detail. We have with us Dr. Majid At-Taneji, senior consultant pulmonologist at Jalila Children's Hospital, Dr. Omi Narayan, senior consultant pediatric pulmonologist and sleep consultant at the American Hospital, and we have moderators, Dr. Kalpana Sengupta and Dr. Diari. Well, as I said, our speaker is Dr. Muhammad Nami, MD, PhD, Assistant Professor, Cognitive Neuropsychology and Neurosciences, Sleep Health Department of Social Sciences, Faculty of Communication, Art and Science from Canadian University, Dubai. Our panelists, Dr. Majid At-Taneji, consultant pediatric pulmonologist and sleep consultant at Al Jalila Children's Hospital, Dubai, and Dr. Omendra Narayan, consultant pediatric pulmonologist and sleep consultant at American Hospital, Dubai. Well, as I said, moderators are Dr. Kalpana Sengupta, senior consultant pediatrician and head of the department at NMC Specialty Hospital, Dubai, and Dr. Diari Muhammad, senior consultant pediatric surgeon at Jalila Children's Hospital. Well, our annual conference, the 10th annual Dubai Pediatric Conference, will be held on 19th and 20th April. It is Friday and Saturday at Swiss Hotel Al Marouj Hotel, Sheikh Zayed Road. We have eminent faculty members, so please save the date. Well, briefly, in 5 minutes, I'll give a brief account of the history of the sleep disorder in children. I always start in the memory of Hippocrates, the father of medicine, and I love his quotation, first do no harm. It holds good in all fields of medicine. Well, the ancient physician Hippocrates once wrote, both sleep and insomnolency, when immoderate, are bad. This is in his writing aphorism about 400 BC. In ancient Greece, hypnos, In Greek mythology, Hypnos is the god of sleep, was the personification of sleep, and Somnos represented the counterpart in Roman mythology. Well, the name hypnosis comes from the name Hypnos. The Hypnos had 3 children. One of them was Morpheus, the god of dreams. The drug morphine is taken from his name, Morpheus. Well, we must know Nathaniel Klitman. Nathaniel Klitman was an American physiologist and sleep researcher who served as professor emeritus in physiology at the University of Chicago. He is recognized as the father of modern sleep research and is the author of the book Sleep and Wakefulness, which was published in 1939. There is an award in his name. I will mention about that. Well, now our question is Dr. Richard Ferber, a pioneer in pediatric sleep medicine. The genesis and development of the field of pediatric sleep medicine in the United States owe much to the work of Richard Ferber. As a co-founder and former director of the Center for Pediatric Sleep Disorder at Boston Children's Hospital, Ferber was instrumental in introducing clinicians to the ways of identifying and treating children's sleep problems, from general sleepiness to more complex medical conditions such as sleep apnea. Well, Ferber served on the American Board of Sleep Medicine, where he advocated for incorporating pediatric sleep medicine competencies into certification exams, and on the board of American Academy of Sleep Medicine. Please note here, he received the American Academy of Sleep Medicine Nathaniel Klitman, which I mentioned, Distinguished Service Award, as well as the Organization Excellence in Education Award, and held position on 3 notable journals. Please remember, an editor of Sleep, an associate editor of Sleep Medicine, and editor-in-chief of the Frontiers in Sleep Medicine, such an eminent personality. Well, Ferber is widely known for his book, Solve Your Child's Sleep Problem, first published in 1985 and revised and expanded in 2006. Those who have not read, please go through. Well, once again, our speaker and panelists, Dr. Mohammad Nami from Canadian University, Dr. Majeda Teneji from Al-Jalila Children's Hospital, and Dr. Omi from American Hospital. Briefly, I would like to introduce our speaker, Dr. Mohammad Nami. Dr. Mohammad Nami is an assistant professor of cognitive neuropsychology and neuroscience at the Department of Social Sciences, Canadian University, Dubai. Dr. Nami is an associate member of Harvard Medical School alumni and member of the Harvard Alumni Entrepreneurs. He is the director of the Brain, Cognition, and Behavior Units at Brain Hub UAE, as well as the former head of Department of Neurosciences and Vice Chancellor for Research and Technology Affairs, School of Advanced Medical Sciences and Technology, Shiraz University of Medical Sciences. His main areas of research and clinical practice are medical, cognitive neurosciences, cognitive neuropsychology, neuroscience of sleep, neurocognitive fitness, neurological aspect of sleep disorders, and related intervention. Please note here, as an MD, Dr. Nami did a PhD in cognitive neuroscience and completed his clinical sleep disorder fellowship at American Hospital, Koch. Foundation, Koç Foundation was founded by Vehbi Koç, the great philanthropist and entrepreneur in Turkey, very well known. Foundation Istanbul. He has also served as a visiting professor at Society of Brain Mapping and Therapeutics at Los Angeles, California for 2 years. Well, these are my references. Beautiful Dubai in day and night. And now I will stop sharing. Before requesting Dr. Nami to start his talk, I would like to mention this point here to our viewers that getting CME for webinar is different for the physical events. For the webinar, we have to record the event and send to the DHA or Ministry of Health, and after a few weeks, we get the reply. I would like to confess here that there was a delay from our side. There was a change in the system of applying for the CME, but I give this promise that Dr. Tawfiq will get the CME, and those who have attended our previous webinars, they will get their CMEs. This is a promise. Now I would like to request Dr. Nami, our speaker, to start his talk. After his talk, the Q&A session will start with our panelists and moderators. Dr. Nami, please, over to you.
Thank you very much, Dr. Saurabh. I really appreciate the fact that the opportunity of sharing some thoughts and the exchange of ideas here has been accorded to me by the remarkable DPC and the eminent members of the organizing committees. I definitely like to extend my appreciation to you, Dr. Saurabh, for sharing with me this opportunity, as well as the excellent panel members, Dr. Diari, Dr. Omi, Dr. Majid, and Dr. Kalpana, and those who are participating in this activity. Well, as you indicated, it's really important to recognize the importance and the significance of sleep-related problems in children, because this specific age group of patients, they have not only issue with their sleep integrity, but also this predicament is going to lead to some, like devastating impacts on their neurodevelopmental, pathway. So through these challenges that they experience, they might be having issues with language development and motor development, might be having issues with their mood regulation and cognitive problems, including attention and memory issues. Many of the children who are having neuropsychological problems, or they might be having some problems in other system organs, including endocrine system or immune system, they might be having some degrees of sleep-related problems. And it is also of note that sleep medicine, both pediatrics and adult sleep medicine, is not only interdisciplinary field, but it is also considered as, better say, transdisciplinary field, because experts from different walks of specialties need to integrate their thoughts and expertise into like multilateral approach to understanding the features of the problem, and then collectively approach in a way which is tailored, which is personalized, and it's going to be as much as possible effective and as much as possible safe to mitigate the problem in terms of sleep-related disorders in kids. And if I may share my screen here, first and foremost, let me highlight that this communication is going to be somehow sort of like case discussions. So I would try to refrain from sharing much of detailed peculiarities about each and every of the things we're discussing here. I'm not going to bore you with much of the detailed things. Definitely, if the DPC agrees, the access to the PDF of this communication material is going to be possible, and each one of you would like to go in more detail and in-depth study of the things later on, you would certainly be more than welcome to have access to this. And I'll be really appreciating also the comments and questions and things that you're going to add at the end of this communication, because this is going to be like a sort of a round table amongst the panel members. And of course, your ideas will be significantly adding to the value of this communication here. Based on the latest international classification of sleep disorders, ICSD, and according to the guidelines of the American Academy of Sleep Medicine, it turns out that we have 84 different types of sleep disorders, both in adults and children. Almost 60% of those 84 different types of problems are commonly observed in children and adults and youngsters. This is really important to realize that we have two different, big categories of sleep-related issues. One of them is dysomnia, means the way that the quality and quantity of sleep is hampered. The other category is parasomnia, and parasomnia are generally referred to as behavioral sleep problems. Some of the clinical sleep-related issues that children are brought to the clinics are being highlighted here, and we have the ICSD code for them. Insomnia disorder, typically we have one special insomnia disorder in children that is even called behavioral insomnia of childhood or BIC. Also hypersomnolence or excessive daytime sleepiness, narcolepsy or sleep attacks, and as well as circadian rhythm sleep wake disorder. Parasomnias could include a realm of different types of behavioral sleep issues, including tooth grinding or sleep talking, sleepwalking, enuresis or bedwetting. And some other children might be having some issues related to sleep terror, or they might be having nightmare disorder, which are kind of different, and we'll be touching on that. The other category of sleep-related problems in children might include sleep-related movement disorders, as they might be having bruxism or like periodic leg movement disorder or restless leg syndrome upon sleep onset. One of the very prevalent sleep-related problems is the sleep-related breathing disorder, or SPD. And children might be having issues with their breathing pattern during sleep. They might not be having regular breathing pattern, or they might be suffering from some limitations in the airflow. They might be having loud snoring, or worse scenarios that we're confronting, the obstructive sleep apnea or hypopnea. In some instances, children, especially the infants, might be having central sleep apnea. That is where the brain does not send the breathing drive from the brainstem areas to the respiratory muscles. And that's why there's no effort in breathing. But in other cases, we have effort for breathing, and there's a signal sending down from the brain, and there's a descending drive from the brain in terms of breathing. But mechanically, the airway is clogged, it's been narrowed down. And that's why children will not be able to have quite amount of information, quite amount of flow, airflow needed to be ventilated, and the oxygen will not eventually be delivered to the brain. That's why they're having this intermittent hypoxia, and this hypoxia is chronically there. And that is why when children comes to the clinics with a wide range of neurodevelopmental problems, and then we try our best, level best to help them, it doesn't work and it doesn't do the trick, because the root cause of the problem, the grassroots is in their sleep, and they have chronic insomnia, or they have chronic sleep-related disordered breathing. What we do in the clinics to help their brain to thrive does not work as if we are riding on water. That's very crucial, because if we do not touch on the root cause of the problem, all other efforts that we're putting together might become pointless. Behavioral insomnia of childhood, as I told you, is one of the 14 different types of insomnias that we have. Restless leg syndrome is sleep-related eating disorder. We're going to meet with the first case, a decent young girl, FN is a 5-year-old child, and the parent took this child to the clinic with the primary concern that the child consistently struggles with falling asleep independently for the past several years. FN parents report that their child is very reliant to specific sleep associations, such as being rocked or having a specific stuffed animal, just to be necessarily be present there at bed. Otherwise, she would find it very challenging to fall asleep. When we have this case, we've gone through a series of evaluations. Of course, the baseline is the medical history and physical examination. For FN, it was insignificant, and the physical examination, neurological examination was within normal limits. The chemistry lab panel, including the CBC and thyroid function test, was within normal limit again. But when it came to the sleep diary, it turns out that FN has some delayed sleep phase issues. She sleeps later than normal, and she wakes later than expected. And that was why not only she herself, but the parents were kind of complaining about that. Although there is a consistent bedtime routine and also the environment of sleep is consistent, there are some issues that prevents her to sleep independently. And there's always a sleep association kind of rituals and patterns that should be always there. For this case, just to make sure that everything is in a good shape and we're not confronting any organic sleep-related problems, we decided to perform, and also the family wanted to have this. So we decided to perform the polysomnography, what is typically referred to as a sleep test. And the results of the polysomnography was generally within expected limits. It was not pathologic, except for sleep latency to N1 or light sleep, which was more than 40 minutes. And for children, it should be less than 30 minutes in general. We also did some other behavioral assessment tests for sleep, including the evaluation of the anxiety, which revealed that FN has minor contextual anxiety disorder, anxiety based on the Beck's anxiety inventory, and also results from the child sleep report, self-report, or CSSR, and pediatric sleep questionnaire and children's sleep habit questionnaire, or CSHQ. We use this to evaluate the behaviors that identify the specific challenges that were there upon sleep onset. All of the evaluations, putting them together, they were compliant with the diagnosis of SOAD, or sleep onset association disorder. Having that into account, now here's a question. If I and you diagnose a case with SOAD, what needs to be done? Should we go for melatonin? Should we go for other pharmacological treatment? Is it going to be the behavioral treatment or behavioral intervention as the first priority? Yes. We should refrain from starting any type of medication unless behavioral intervention does not work. That's why behavioral sleep disorder experts, specifically in the context of pediatric sleep issues, would be of tremendous help. And they would provide the parents with some insights and recommendations in terms of re-entraining the bedtime habits and bedtime rituals. One of them is called bedtime fading, and that's the gradual fading of the time, or advancing the time and of sleep or the bedtime, and letting the child to be independent when it comes to the onset of sleep in a child with SOAD. We got to be gradually adjusting the child bedtime in small increments, aligning it with the time they typically fall asleep. For example, if it's 10 p.m. on day one, we need to fade it and a little advance it to 9:45 the next day, and the next 2-3 days, we need to just advance it to 9:30 p.m. and 9:15 p.m. And by this, we're trying to foster more adaptive and self-sufficient sleep habits. And then by time we're gradually going to make extinction, we're not staying with the child like before in the bedroom. There is another behavioral intervention called gradual extinction. And it's like the parental presence during bedtime got to be gradually reduced. And the child needs to be slowly and gradually withdrawn from the already in place sleep environment. And the context is going to be kind of changed in a way that the child will find it self-soothing, and the techniques will be implemented gradually. There has been a very comprehensive review discussing the extinction-based behavioral sleep intervention for young children. And it has been discussing the fact that some of the parents, they don't comply with this and they find it very difficult. What was the reason behind it? Because we have different types of extinction sleep intervention, and it is even popular amongst parents, and they know, they have heard about this, they have read about this, like anecdotal suggestions. There is an unmodified extension, or like graduated extension, and extension with parent presence. While each of these, they might be having their own pros and cons, some of the parents find it really challenging because they would say, well, we'll leave the child alone. But problem is that there is enduring crying, or we have practical consideration, it's not actually workable. And also we are kind of concerned, and we have the fear of repercussions. And misinformation that they have heard about it would prevent them from complying with the gradual extinction. And also the incongruence with the personal beliefs and like different cultural practices and parent wellness, they feel really sad, anxious, depressed, and stressed. So when the child cries, they cannot bear up with it. And that's why they again get back on track. The same thing, same problem, same patterns, and the scenario goes on and on. But one of the other very pragmatic ways of putting solutions into place is to go for the positive bedtime routines. And that is also, that holds true for many instances. The bedtime routines could be printed on a piece of card, and it could be checked with the child each and every night. And we can celebrate if one positive behavior or one positive routine is being implemented tonight, and then we celebrate it together. For example, reading time, the brushing teeth and bath or wash up, having a snack, put on pajamas in order. When we succeed to implement one other adaptive habit for bedtime routines, and we celebrate that, we cherish this together with the child. So the child next night might be even bring in this, because the night before the child received some reward and appreciation for this. The next night, he or she might be bringing this card, and we're playing the same game, just checking the boxes, making sure that all those 1, 2, 3, 4, 5, 6, 7, 8 habits are being followed closely, and based on the positive effect through which the child will find it easier and more calming to fall asleep based on these. It's going to become the routine for the child. And after like few weeks, there is no need to even get back to this card, and the child is following that automatically. The importance of consistent sleep environment, that's also very crucial, because the environment is a vital part for managing of the SWOT cases. Like a quiet, dark, comfortable, little bit cooler than usual sleep environment is going to help the child to have a better capacity of falling asleep and staying asleep. Otherwise, it's going to be disruptive, and that can hinder a child's ability to fall asleep independently. Of course, the parent involvement is as a central importance here. And when we're addressing SWOT, parents need to be playing a central part in that. And they got to be providing emotional support as a key to providing support and bringing the self-confidence to the child that, yes, I can sleep independently, and I'm grown up. I have the support of my parents next door. There is no need that I have them next to me. Open communication between the parents and the healthcare provider is also essential for effective management of these SWOT cases. And that was case 1. Case 2 was about a 6-year-old child facing challenges in sleep, and she had challenging sleep situation. SA was grappling with episodes of intense fear and screaming that occurred during the first few hours of sleep. So she was like getting woken up, dazzled, looking around, not being fully aware and conscious of the surrounding, and she was staring at somewhere, just screaming. And the episode, these episodes have raised significant concerns with SA's parents, and they are troubled with the frequency and severity of these nighttime events. So they brought this case, the 6-year-old child, to the clinic, and they were saying that this is being a more frequent incidence as compared to before. Before, we used to have this like intense fear and screaming episode once or twice a week. Now we're almost having that every other night. For the SA, we did the medical history and physical examination, and it turns out that she had enuresis, and she had one episode of febrile convulsion when she was 2-year-old. Otherwise, the physical examination was within normal limit. The lab tests were normal. Sleep diary was reporting regular sleep-wake patterns. And when we did the parental interviews, it showed that, all right, SA also had a consistent bedtime routine and sleep environment, and she was able to sleep independently. We did the polysomnography because in those cases, when we're confronting an issue that questionably could be a case with more, extensive possibilities, and there might be some differential diagnosis here. Is that like nightmare disorder? Is that sleep terror? Is that like, it might be some issues with other types of parasomnias, and it even might be sleep epilepsy. So we should have gone through polysomnography, standard polysomnography, which is in accordance with the American Academy of Sleep Medicine. Some sensors are being attached to the surface of the body and scalp. And based on that, we're recording from 18 different channels. And I know we got sleep experts here on the panel, and they're going to help us understand more about their experience with the children with sleep terror. The sleep latency to A1 was a little bit prolonged. It was 43 minutes. We had no evidence of sleep epilepsy. No focal or paroxysmal or epileptiform discharges were found in the time series study of the sleep EEG throughout the night in different stages of sleep. Whereas we had left temporal alpha predominance in N3 or non-REM 3 sleep, which is kind of like slow wave sleep or deep sleep. There was no sleep disorder breathing, no apnea, no hypopnea event, and no flow limitation. But also we have autonomic arousal instability. And there were spontaneous microarousals, and there were like on average 12 to 13 microarousal events on average per hour, which gave to which raised the index of 12.8 arousal as an arousal index. The wakes after sleep onset was like 6. So she was being woken up, and she woke up after the sleep onset for like 6 times on average per hour, hour of total sleep time, but she was not necessarily aware of the surroundings. 1 or 2 of those episodes were quite robust, and the child was kind of very dazzled, apprehended, screaming, and altogether, she has had like 485 minutes of total sleep time, out of which she spent 42 minutes awake. The WASO or wakes after sleep onset episodes collectively accounted for 42 minutes. We also did pediatric sleep questionnaire, and we also proceeded with the children's sleep habit questionnaire together with, they were together compatible with sleep terror diagnosis. And now we need to understand about this abnormal predominance of alpha wave in the left frontotemporal lobe. So this is the sleep EEG, and actually that's the quantitative EEG. And in the temporal area, as you see here, we have slowing or transient slowing, and we got some predominance of the alpha waves here, which is different to the background. But when it comes to the left frontotemporal derivations, we need to also understand if this is compatible with chronic anxiety disorder or separation anxiety disorder. What has caused this issue? But fortunately, we did not see and we did not witness any evidence supporting sleep epilepsy for this kid. There is a differential diagnosis for night terror, as you all know. one most popular differential diagnosis is nightmare, but we need to comparatively put them together and analyze the symptoms and make sure, are we confronting a nightmare disorder or night terror? For the night terror disorder, we know that night terror happens in non-REM sleep, rather than REM sleep. And they have intense fear and screaming, difficult to console the child during the episode, and they have limited awareness of the surrounding, and the child might not remember the episode upon wakening in the morning. On contrast, for the nightmares, we have the occurrence of the episode during the REM sleep. Sometimes they kind of act out their dreams. They might be having some REM without atonia, they have sleep talking, or they might be having some apprehended wakes during REM sleep, and they are very scared, they are crying, but they can remember exactly what they were going through, and they can verbalize it, they can talk to you about that, and they are pretty kind of conscious about the surrounding, and they have vivid and frightening dreams, and they can recall, as I shared with you, they can recall even with details what they have been going through. It's easier to console the child after a nightmare, and they have high awareness of the surrounding during the episode. Now, we need to kind of differentiate these two in a very distinct way. For the night terror, for sure, we have non-pharmacological approaches, which are going to come first place. And most importantly, we need to make sure that we maintain a consistent sleep schedule and ensure a comfortable sleep environment and reassure the parents. If the problem is rooting in only hidden or covert anxiety or separation anxiety by child, or we have some other emotion dysregulation problems, this can be, pretty much addressed straightforward by the child psychologist. We might be having some counseling, we might be having some parenting sessions with the parents, of course. And based on that, most of the issues are going to fade away after a period of time. But when the behavioral approaches does not do the work, and still we have problem, which is like refractory to the behavioral approaches, eventually we got to be going for the pharmacotherapy, and that is reserved for severe cases. The medication is typically viewed as a last resort because we always need to consider the potential side effects of medication, and we definitely got to be seeking a guidance for prescribing the medications. Some medications could be typically used for night terror. They might be some medications that you're downscaling the sympathetic nervous system tone, or they might be medications as antidepressant medications. But always we need to consider that non-medicinal approaches could be of more value when it's applicable. Other treatment solutions could be relaxation therapy, hypnosis training by child psychologists, and some other modalities, including neuromodulation, have already gained support by the scientific evidence, including biofeedback or neurofeedback. Or when we're putting together these things with behavioral approaches, what we call it neurobehavioral approaches, they are going to be of even more significant value. Okay, and I'd like you to meet our third case. Collectively, we'll be having 4 cases, and I'll be wrapping up hopefully in 15 minutes, 15 to 20 minutes max. MT is a 9-year-old boy who came to our practice, and he's been exhibiting restless sleep. He's been snoring loudly. He's even been snorting during sleep. And there has been some episodes of breathing cessation. So some transient pauses in sleep was witnessed by the parents. And they're saying that he was kind of choking, and we were totally scared that he's not breathing. And at some level, we had to wake him up. The parents were concerned that they have noticed the symptoms, and they are worried about his overall well-being and daytime behavior. Because in the daytime, unlike the adults, children might not necessarily show the symptoms of excessive daytime sleepiness or somnolence during the day, like what we do. If I did not have a good night's sleep last night, today I feel sleepy and I doze off the wheel or I doze off in a meeting. Everyone noticed that I have some, sleep deprivation and I feel sleepy, and I can show that in my face. But in children, it's not like that. When they are chronically sleep deprived or they have inefficient sleep, they might be representing the symptoms of this predicament by restlessness, irritability, hyperarousability, oppositional behavior. They might become aggressive or they might become hyperactive. So the MT was showing some sort of disorganized behaviors and oppositionality in his behavior in the daytime hours. And he was not performing well at school. So the family seeks insight into the potential causes and solutions for this sleep-related breathing issue that has been affecting the child. Again, as usual, we went for the medical history and physical examination as the foreground for all the different approaches. The medical history was insignificant. The physical examination was almost within normal limit, except for the examination of the back of the throat. When we're checking the back of the throat of MT, this 9-year-old boy showed that he has a very busy soft tissue. I mean, the back of the throat is very packed up with the soft tissue. For instance, he had like bulge and enlarged like adenoid tonsils and also palatine tonsils. And he had a wide-based tongue, and the soft palate was low-lying. And based on this, for those of you who are familiar with the Mallampathy classification, the Mallampathy class for this child was 3, which is kind of like short neck with a very crowded back of the throat tissue. No tonsillar hypertrophy for this. Palatine tonsillar hypertrophy was there, but further evaluation revealed that he had adenoid tonsillar hypertrophy, which was not at the level that was going to be excised by the ENT. And on examination, he also had normal heart and lung examination. The chemical workup, the chemical lab workup were within normal limits. And when we did the sleep diary record from him, it showed that he has been showing some fragmented sleep, and he did not have like well-integrated sleep with so many WASOs and so many reported of prolonged WASOs or wakes after sleep onset as reported by parents. The parental interview revealed loud snoring by MT, and also tossing and turning a lot, kicking in bed, witnessed short pauses in breathing while he was asleep. And we did the polysomnography. The entire polysomnography was compatible with the diagnosis of obstructive sleep apnea hypopnea syndrome. And for those of us who are familiar with AHI is an index which stands for apnea hypopnea index, and it should be less than 5 to be regarded as normal. For this child, it was 68, which is profoundly higher than expected limits. But interesting point was that for MT, most of the respiratory events were predominantly hypopneas rather than apneas, and he was having this kind of limitation on the airflow. And almost because of the narrowing of the airway and the partial collapse of the upper airway and the resistance of the upper airway, almost like, let's say, 60% of the air, which is supposed to be in, it's going to be stolen and it's not going through. So that's why the child could be breathing like this during sleep. This is called hypopnea or flow limitation. We also check for the pressure and also the flow. So both of them are some metrics that put together the diagnosis of apnea versus hypopnea. In apnea, there is a respiratory effort, but there is no exchange of flow. It's like this. There is effort. The child is struggling to take breathing, but it does not work. He has irregular sleep habits. And also when we did the evaluations for the attention performance, the evaluation suggests that there's a significant attention deficit as per the CAN-TAB attention battery. And they were significantly lower than expected Z-score of -1.5 and -2 for divided attention and vigilant attention, and that has been negatively affecting his school performance. He has had oppositional behavior, hyperactivity, and vigilance. Diagnosis was the bottom line diagnosis so far was obstructive sleep apnea hypopnea syndrome, OSHS. This is a snapshot of his sleep report. On the top, you see the hypnogram, which shows that he finds it a little bit difficult to fall asleep. It takes a little bit longer than normal for the sleep latency to N1. And also, we have had the total sleep efficiency of 59%, should be above 85% for children. And the sustained sleep efficiency was 67. Still, we have a large gap to fill. And when it came to the number of the wakes, it was 26. So 26 vasos, and the vaso sleep period time was 2 hours. For this child, it was very fragmented sleep. So he was significantly suffering from sleep fragmentation. When it came to the distribution of sleep stages, it turns out that we have a pretty good amount of N2, which is the mainstream sleep. It's not shallow sleep, and it's not light sleep, it's not deep sleep. It's somewhere in between, and that's the key component of our sleep journey. For him, the N2 percentage was 63, which should be almost like that. But when it came to the wake, or the white part of this pie chart, you see that most of the time of sleep he has been having this prolonged vasos. And when it came to the respiratory event analysis, he had 37 of obstructive apnea, no mixed or central apnea. But interestingly, he had 385 hypopneas. Putting that into context, the RDI, or respiratory distress index, or the apnea-hypopnea index per hour, events per hour for MT was 68.2, which should be normally less than 5. So there is a huge deviation. And there were some respiratory effort-related arousals. And also we have had intermittent hypoxia. There were 614 episodes of drops in the oxygen level, more than 3%. And the minimal SpO2, or the arterial saturation of blood oxygen, it was 81%. The baseline oxygen was 91%, and the nadir O2 was 81%, which is pretty significant. And this has been rooting in also the snore. The snore has been a symptom of the sleep breathing disorder for this 9-year-old boy. He's been snoring through the study for 4,919 times, and this snoring has not been position dependent. No matter if he was on the left or right side or supine position, he continued snoring. And there was like 55% of the total sleep time whereby he spent snoring. There were different types of microarousals, but the majority of the events for microarousals were related to the respiratory issues and the desaturation events. What should we do? If we're leaving this child untreated, this is not only going to continue aggravating the behavioral symptoms, but also will lead to his school performance issues. Many of these children are wrongly being labeled as learning disability or LD children. They might be labeled as ADHD. This child is suffering from sleep-related breathing problem, but he's being prescribed Ritalin during the day, and the condition is getting even worse. There are different approaches. For this child specifically, we went for APAP, or automatic positive airway pressure therapy, or APAP therapy, and we had a range between 6 to 12, and it was found to be doing pretty good at the pressure of 7.5 centimeter H2O. And he was doing fine, and after a while, the symptoms of a sleep problem alleviated, and it was doing pretty better in terms of his behavior in daytime hours. One of the approaches for such children could be adenotonsillectomy, or some ENT expert might prefer to go for another special surgery, which is called UP3, or uvulopalatoplasty. We cannot do adenotonsillectomy, we better refrain from it. But we generally need to consider that the success rate would vary based on the individual cases and underlying cause of the OSHS. It's not like every child with OSHS needs to undergo adenotonsillectomy. Many of the instances we go for the positive airway pressure therapy or PAP therapy, which is a non-surgical treatment, and that is one of the gold standard approaches for the treatment of sleep disorder breathing problems. We might also be considering some other measures like weight management or the positioning, as you can see in the picture here, positioning of the oral appliances or the mandibular advancement devices. And there are other approaches, including the medication therapy, just to decrease the resistance of the upper airway and just to alleviate the congestion because of the air trauma over and over again during the sleeping hours. We might be prescribing inhaled corticosteroids, long-acting beta-2 agonists, or leukotriene receptor antagonists, including montelukast, for example. And this has been proven to be efficacious for many of the cases of children with obstructive sleep apnea, hypopnea syndrome. The last case that we're going to discuss about here is a 13-year-old teenager, a young girl who's been grappling with sleep challenges, and she's been continuously having problem with falling asleep before 2 a.m. He's been using technology. The screen time is all over the place over the evening hours, and she has been looking into social media and stuff. She's not been following the sleep hygiene measures, and that's why she's struggled to wake up on time in the morning, and she's been missing the morning classes. This has been leaving adverse effects on school performance and causing daytime sleepiness for her. This sleep-related issue has prompted us to pursue exploration of the potential underlying problem and interventions to address AKID's disrupted sleep-wake cycle. So this is more of the sleep-wake cycle. She sleeps late, she wakes up late. And she was feeling like tired, fatigued, gloomy, having headache in the morning, and she was not up and ready and about to start off the day in an energetic way. We have been trying to mitigate this condition by re-entraining the sleep phase of this child. Medical history and physical were normal, chemistry panel normal. Sleep diary showed that she had delayed sleep phase pattern. The parental interview said that, well, she wakes up very late and she misses morning classes, morning fatigue, and dysphoria. When we're approaching these cases, we give them the sleep diary, and it provides us with, or a sleep log, it's also called sleep log, and it provides us with the insight regarding the sleep-wake pattern over the past 2 weeks. Or they might be wearing the actigraphs, which is the accelerometer, to provide us like digital reading of the sleep-wake pattern over 2 weeks. For those children with a delayed sleep phase disorder, they wake up late and not refreshed. Some of the children might be having advanced sleep phase disorder. They sleep early and they wake up in the middle of the night and like very early morning. And they also got issue with the social timing and congruence of the social timing with the biological clock. Some of them, they don't follow any specific pattern and they have irregular sleep phase disorder. And it has something to do with the melatonin, with adenosine, with neuromelpeptide, with their exposure to light. For example, for the case of AK, she's been exposing herself to blue light, which has been hampering a surge of melatonin at the late evening hours. The polysomnography, which was done for her, was uneventful, but the sleep latency to N1 was more than 185 minutes, literally 148 minutes. The behavioral assessments showed that he has moderate anxiety based on the PECS anxiety inventory, poor sustained and divided attention, significantly impaired working memory based on the REHACOM screening, which is a German platform for like consolidated evaluation of the cognitive profile of those cases. And she was doing, unfortunately, really poor in terms of working memory. And she has also excessive daytime sleepiness based on the Epworth Sleepiness Scale, or ESS. It's a scale between 0 to 24, and we consider that acceptable when it's less than 8. For her, it was 18. This means that she has been expressing excessive sleepiness during the daytime hours. The diagnosis was delayed sleep phase disorder and sleep phase syndrome. In this figure, as you can see here, we have the characteristics of like a normal sleep wake cycle. This is the normal sleep wake rhythm, and the biological rhythm is compatible with the social clock. So the body clock or the biological clock is in check with social clock. But here,
Sorry, Dr. Nami, 5 minutes, please.
yeah, less than 5 minutes, I'll be concluding. Thank you very much for the notice. Well, in this child would sleep late, wake up late. This child sleep early, wakes up early in the middle of the night, and this child has irregular sleep phase disorder. And we just need to re-entrain, and we need to help them to have entrainment of the biological rhythm. Sometimes we got to go for melatonin, dim light melatonin onset titration at evening hours. So we get the saliva, we send it to the lab, and then we get some readings of the melatonin onset. Based on that, we can give them melatonin. If it turns out that it got problem with the melatonin surge in the late evening hours, melatonin supplementation could be very helpful. But it's not like that we go to the pharmacy and we get melatonin as an OTC medication without titration, without timing. So melatonin is a long story, and we need to be taken to account that the adjustment and calculation of the dose of melatonin and timing of melatonin prescription is a key to its efficacy. We also have this, through this approach, we're going to take the delayed sleep phase disorder and turn it back to the normative and expected sleep phase pattern. This holds true for many instances, and unfortunately these days students and schoolers are not following the sleep hygiene measures, and they are really, obsessed with the technology and stuff. So we need to encourage them to follow the sleep hygiene measures and raise awareness. We need to evaluate the natural sleep tendencies for them and assess the individual circadian rhythm and sleep preferences. We sometimes need to assess their need to have exposure to light therapy in the morning, and also supplementation with melatonin or other sleep aid medications in the evening hours. Variations should be also taken into account, and based on that, we might be moving on with therapeutic approaches. There might be non-pharmacological interventions or pharmacological interventions. For non-pharmacological, the key 3 examples could be light therapy, sleep hygiene practices, and cognitive behavioral therapy for insomnia or CBTI. For pharmacological therapy, we've got to be considering melatonin supplementation or other medications as indicated if non-pharmacological interventions prove insufficient. I really appreciate your attention. I know it was a little bit long, and I really appreciate your patience, and truly thank you for your undivided attention through this conversation.
Thank you very much, Dr. Nami, for the excellent informative talk. And now, could you please stop sharing so that, thank you very much. Now I would like to request our expert panelists and moderators, Dr. Omi, Dr. Majid, Dr. Diari, and if Dr. Kalpana is there to join us, I would like to request Dr. Omi to start the session, followed by Dr. Diari, please. And I would like to request our viewers to write their questions in Q&A box so that our panelists will answer those. Please.
Dr. Nami, that was an amazing, very, very comprehensive talk. And I feel that you covered pretty much all pediatric, sleep-related disorders that we will come across. So thank you very much for a very comprehensive.
That means a lot to hear that from you. Thank you.
So I had few questions, and if you could just shed some light on that. So you do a very detailed evaluation for all your sleep cases. So what would you recommend that if for general pediatricians they come across any sleep related problems, could they do any questionnaires? How could they screen in their practice, in their busy practice? Because as you know, the sleep evaluation takes a long time, and most of our general pediatricians are seeing patients in 10, 15 minutes. And during that time, any sleep questionnaire or any screening questionnaire that they can ask for?
Yeah, it got to be practical, because these cases are the cases that we have vertically analyzed. So we've been comprehensively analyzing these cases because some of them were really worth to be case reports, and the parents were also interested to get through that. And we wanted to know what is the baseline issue now, and what has been the basic biomechanisms that is explaining this predicament in those childs. Of course, it's not necessarily being done for each and every single child that comes with sleep disorder problem. But if you experts as pediatricians, you kind of suspect that the problem you're facing with, for whatever organ system that is kind of possibly rooting in sleep issues, then it is worth to give it a deeper look. We might be referring to the sleep expert, and based on that, a child psychologist or like a sleep fellow will be administering some behavioral sleep questionnaires and stuff like that. If indicated, together with you, we decide whether a sleep test is required or not, and based on that, we pursue. It's important because we need to go for the sleep checkup at least once for the children that we have a big question mark about their sleep. If it's not the case, then we can just follow through and make sure that sleep is not an issue.
Sure. One more question I had, I could see that you do complete blood count and thyroid evaluation for all these children. Is that your normal protocol, and is that something that you would recommend for?
So again, that is not, no. Thank you for asking. This is not a normal protocol, but since we wanted to, for example, rule out any issues regarding their like general health, and we wanted to make sure that, because these cases, when we were having them, like some of them, they were having some behavioral issues, and the question mark of having some, metabolic issues or blood-related issues or whatever, we were just going to make sure that there is no organic problem there, and that's why it's not a routine practice that for each and every single individual coming to us we're going to go for CBC and other complete blood test panel. No, it's not. But for these cases, we do.
Great. So we have some questions popping from the audience, and a lot of thank you for clear talk. One of our attendees is asking that how could you give any recommendations? How can the quality of sleep be improved, particularly if it has come from poor sleep, is coming from chronic pain, back pain, any post-operatively, and what can you do in terms of to make sure they are getting enough oxygen during this sleep problems? Are there any like non-surgical behavioral interventions that you could recommend?
Yeah, is that a question to me?
Yes.
Oh yeah, sure. Yeah, for the post-surgical pain syndrome, if we are having like a persistent pain, we need to make sure if the patient is receiving adequate and appropriate analgesic. If that is the case and the person needs to undergo specific, rehabilitation measures or something, we need to pursue that. As I said at the beginning of my talk, it's a transdisciplinary, not only multidisciplinary or interdisciplinary approach, it's a transdisciplinary approach. And that's very helpful that we sit together, discuss about this with the panel of experts, decide that what needs to be done. But if I'm going to decide about this case, first I will review the medication regimen to make sure if the pain has been properly managed or not. Is the pain been rooting in emotional dysregulation or stuff like this, or depression, for example, after the long period of immobility or lack of social interaction? If that is the case, then sometimes we also need to go for antidepressant medication therapy or this and that. If we need to mitigate the emotion dysregulation problem through non-medicinal approach, something like meditation, mindfulness-based cognitive training, CBT, and stuff like this could be appropriately touching on the case. And some of the time when the pain is like a centralized pain, there is no, justification for this intense continued pain, but we see that the pain is just originating between the ears. It does not have any peripheral origin. So based on that, we got to be touching on management of the central nervous system related pain mechanisms, and go for relaxation techniques, meditation, biofeedback, neurofeedback, or specifically if the situation implies we got to be going for a transcranial electrical stimulation, transcranial magnetic stimulation when they are complying with the guidelines and we have clear indication.
Great, thank you.
Dr. Majid has not joined
Dr.
yet.
Majid. I think Dr. Majid was
Dr.
asking
Diari,
a
you
question.
can, if you have any question, please.
Thank you, Doctor, for this nice and excellent presentation. My question, so many mothers coming to the clinic and asking, how much do my child need sleep? What's the normal according to age?
Well, it depends, and it's a kind of important age-related issue whereby children might be having different levels of sleep-related needs, and based on that, we need to know that as per the age range, the need for sleep could vary. And of course, for the infants, the total sleep hours needed is way beyond and way more than the other children of different ages. For example, for 0 to 2 months, we have 18 hours of sleep need, or 16 to 18 hours of need. And as the child grows and by age, we'll be having less and less number of the total sleep time needed. For example, for a 2 to 3 year old, we're tapping into like 12 to 14 hours. But when it comes to, these are for toddlers, but when it comes to young kids, they would be needing like 6 to 8 hours ultimately. So when it comes to age of a 9-year-old, we were talking about something around 8 hours and 6 to 8 hours. And for adults, this is something between 6 to 7 hours. But below 6 hours, no one needs below 6 hours. But if we're answering that question, how many hours of sleep do I need? The question is very straightforward. Listen to your body. Some people are long sleepers and some people are short sleepers. If I'm okay with 6 hours of sleep, that's fine. But typically, it's not going to be like 4 hours of sleep is going to be considered sufficient, or 5 hours of sleep is going to be considered sufficient. Most of the instances, the 6 hours of sleep is the least amount of sleeping hours which is recommended for adults. And for children, 8 to 9 hours.
Okay, do we have a sleep quality index, something like that? How we measure objectively?
Objectively, if someone is asking about the quality of my sleep, I can give one specific questionnaire which is designed for this, and that belongs to the University of Pittsburgh, and it's called Pittsburgh Sleep Quality Index, or PSQI. And the PSQI is a scale score which gives me like a general view. Well, if the PSQI score is above 8 and above 9, then we have poor sleep. And when my sleep quality and quantity is poor, and I need to depend on medications for my sleep onset and sleep maintenance, and if my PSQI score is higher than normal or higher than expected limits, then I need to consult a sleep physician and sleep expert. Or I might be referring to my primary care physician, and he might be referring me to a specialist for this. So of course, one of the things that people can tap into it, two questionnaires are very important. Number one is a STOP Bang questionnaire for the possibility of sleep apnea hypopnea syndrome and the pathologic snoring. STOP, like S-T-O-P, Bang, B-A-N-G. They want to give it a search. The other one is PSQI, and they can freely access these two questionnaires to ensure how they're doing with their quality and quantity of sleep and the possibility of undergoing some challenges, including sleep-related breathing issues.
Dr. Majid?
Dr. Majid, Omi, you can give also your expert opinion.
I know you have been devoting your career, most of you, to sleep research and sleep practice. So please help with your insights, because that matters a lot, both to me and the other participants here.
Sure.
Please,
Dr. Majid, I'll let Dr. Majid ask question and then I will contribute.
Sure, yeah, appreciate it. Thank you. This is very extensive, seeing most of those cases in the pediatric sleep clinic. So just I'll start probably with some questions and then maybe follow up with some, important take-home messages. So I think for the case one, the sleep onset association, would we consider a sleep study for most of those patients, or will consider history as just a straightforward diagnosis?
Typically, it's not indicated that a case with SOAD would need to undergo polysomnography. And in real practice, like 7 out of 10 of even severe cases that we see coming to our doors, we do not go for PSQ. But for the cases that we definitely need to investigate something based on our examination or clinical history and something, and there's still a remaining question mark, and we need to tap into that question mark. It's a very, wise idea to investigate through PSG if it is, number one, indicated as per the clinical discretion of the expert, number two, if it is feasible. Then based on these two, when we do that, we're going to rule out or rule in something which is going to completely change the direction that we're going to put in play. But yeah, it differs case by case, but as a rule of thumb, we do not need to let the patient undergo PSG when it comes to the clinical scenario of the SWOT.
Yes, completely agree with you. If there's always a doubt about a comorbidity, definitely a sleep study would be indicated. Now, the behavioral insomnia is, very dear and near to me. I just wanted to add, now when we talk about like behavioral modifications, what I wanted to highlight is that not one size fits all. As you've mentioned, different types with different concerns. And the unmodified extinction has had a bad rap among the population. Not everyone's very keen to it. And what we want to see when we want to implement those behavioral modifications is that asking the family what fits them. So discussing with them each and every behavioral modification and seeing what fits. And sometimes you find that one parent prefers a certain behavioral modification than the other. And here is the main issue. Both parents need to agree on one technique, because implementing it is going to be the major challenge. And I see you smiling, so you know what I'm talking about. Yes.
That's a very common practice.
Yeah. So because what happens is that you're preparing for failure from the beginning if both parents don't agree on something, and they come again to your clinic saying, Dr. Nami, nothing really worked. The other thing I wanted to highlight was alerting patients or the families about what they call a post-extinction burst. So what we end up with a success maybe for the first couple of days, and then the child, will have that outburst, but that shouldn't deter the families from continuing to practice that behavioral modification. Just to let them know about that. Have you had any success with, identifying night terrors by just a video recording? Because I'm sure many families come to you with video recordings.
Yeah. It is possible to differentiate night terror from nightmare, because when the child is kind of, disoriented to the surrounding, and this is a typical, textbook way of explaining what sleep terror would look like. But in some instances, it's hard to tell. And for example, for some cases that they have had questionable history of seizure-like behavior, or even 1 or 2 febrile seizure, we don't know if the child has sleep epilepsy, or there could be some epileptiform discharges, which decreases the threshold to all epileptic events, specifically at night. So we had nocturnal frontal lobe epilepsy that is kind of frequently encountered in cases with sleep epilepsy. We need to differentiate this. Again, it depends to the level of suspicion that we as clinicians would have when we look at that video or the series of videos. If we're convinced that this is sleep terror, then we need to first go for the behavioral sleep modifications and this and that. And in most of the instances, that's going to be helping the situation. But if I'm still in doubt, it's better to stay on the safe side and do more of the investigations when it is indicated in not typically all cases, but when it is indicated, we got to be going for a polysomnography test. But sometimes we do this like actigraphy in something to make sure that how many hours the child is spending awake overnight for the past 2 weeks. So actigraphy or sleep monitoring, the home sleep testing could be, but home sleep testing has not been approved for children. But generally, just to make sure that we do the least as possible, we go for it. But the gold standard is to let the patient undergo polysomnography at a hospital setting.
Yeah, yeah. And it's important also to see if there are any comorbid medical conditions, such as OSA. If it coexists, then it could be one of the triggers of arousals, restless leg, or
Absolutely.
periodic limb movement.
Tooth
So I do
grinding
agree
also.
with that. Yeah, yeah. We'll take a question from the attendees. I think so. The question here is how much are allergies, especially allergic rhinitis, contributing to OSA? Do you see that in your practice and evaluate for OSA even after an adult tonsillectomy?
You know, fact of the matter is that according to the reports and the published evidence, we know that almost more than 70% of the cases with obstructive sleep apnea hypopnea syndrome, they have issues with the back of the throat. And it has little or almost nothing to do with the nose. And when we have a problem with the nose, of course, for those children who are nose breathers, it might bring in some challenges for them. But when they have nose blockade, they will just do the mouth breathing, right? But when they have the back of the throat blockade, and they have large tonsils, or they have low-lying palate, or they have wide-based tongue, or they have large uvula, or they have this and that, or short neck, or weakening of the neck muscles. When the cases or like positional process, when the case is that, then if we're just opening the pipes in the nose, it's not really going to help, but because the problem is rooting somewhere else. In cases with allergic rhinitis, there could be some, it could additionally contribute to the severity of the symptoms, but it is generally not the primary issue. The primary issue is sitting back at the back of the throat, or the nasal, or the pharynx, at the pharynx.
And sometimes you would see that with the allergic rhinitis, there can be some inflammation of your inferior nasal turbinates, which is causing some proximal obstruction. And these are the cases, even like post-adenoidectomy, you might see at least some snoring going on, and that can lead to some fragmented sleep, as you said, because of primarily mouth breathing, mouth getting dry, and then they can wake up. So in those cases, maybe you can try some inhaled nasal steroids,
Correct.
and that can be
As you
helpful.
indicated, Dr. Omi, snore arousal is also very prevalent. And snore arousal hampers the integrity of the sleep, and rapid stage transition, and lack of macrostructure or microstructure of the sleep integrity. Arousal has got different classifications, as you appreciate, but snore arousal is also important. In this case, nose plays a role, definitely.
And one of the things that pretty much as pediatricians we should ask, like I normally teach when I say that, just two questions: does your child sleep enough? And does your, just as a screening questionnaire, because I see there are a lot of cultural differences in this part of the world, because particularly we all think that 4-6 hours of sleep is enough, and most parents are working late, they come home late, kids are awake, they're awake till midnight, all schools start early, and they wake up early morning, they have to travel for 1 hour. So most kids, they're not getting enough sleep. Most kids. Number two, it gets worse during the festivities. We know that Ramadan comes and no one sleeps, none of the adults, none of the children. We have late clinics, my children coming to my clinic at 11 p.m. And that tells you that they're not sleeping enough. So just kind of as a questionnaire, that are you getting enough sleep? And that's where telling them that how much sleep is required. That's number one. Number two, most parents also think that snoring is normal. And again, I get quite commonly asked that snoring is normal. Snoring is not normal. So it's yes, we can have 20% of primary snorers, which they might have snoring when they're particularly tired and if they have viral infections. But if they're snoring on daily basis, on every night, whether they're tired or not, that's not normal. If they have daytime naps and they are snoring, that's not normal. So these are the children who should be seen in sleep clinics being run by the specialists, because they do need screening and they do need further evaluation. So just kind of, from general pediatric point of view, what can we add and how should they screen in their clinics? This will be a helpful kind of way to look into that. So moving on to one of the questions from attendees, And I was going to ask as well, because you mentioned that normal AHI for children is like up to 5. And generally there is, as you know, there's slight different classification. In children, we say that 1 to 5 AHI suggestive of mild obstructive sleep apnea, and
Yeah, I can
5
agree
to
with
10
that. Probably that was my issue, my mistake. One
Yeah.
to five, as you indicated, 1 to 5 is typically referred to as mild OCHS. Over 5, that will be considered like
moderate,
moderate.
and then
Yeah,
severe
exactly.
above 10.
And severe above 10, correct. So
Correct.
we're a
So-
little bit more intense in terms of working with children with the OSA based on the AHI, correct.
Correct. And normally my approach is that if we have done a polysomnography or home sleep study or whatever we have done, and AHI is between 1 to 5, majority of time we can try doing some conservative management, and that's by, again, intranasal inhaled steroids or the Montelukast as well. But you mentioned, and that's what the question asked, that could you elaborate on the use of ICS LABA for like OSA? Is it only for asthma children, or like is it for general OSA?
I'm sure as a pulmonology expert, this refers to you. This is your question, not my question, Dr. Ami.
So from my practice, I wouldn't use like any long-acting beta agonist or asthma treatment as such for obstructive sleep apnea, unless they have some underlying comorbidity like asthma. Then they are on that, and you improve their asthma, their sleep might improve, and that way it might work. But for primary sleep problems, that's not one of my practice that I would use. Would you agree, Majid? I'm not too sure is something that you would use.
Yeah, so intranasal steroids and Montelukast, and then they've been proven in some studies to, when they're put together, they'll be more effective. I think if there's a comorbid asthma, then that would be for the asthma itself. Yeah, and I agree with you.
So
Mohammed, can you elaborate more on bedwetting and sleep disturbance, please? Because we have, to be honest with you, we have a lot of bedwetting patients, and usually we, when they are referring to us, we are saying that they are deep sleeper. They are not waking up easily. So, can you elaborate?
There are many, and thank you so much for the instruction, Dr. Diari. The issue is that bedwetting, as we all appreciate as pediatric experts, it has many different root causes. And first and foremost, it could be behavioral problem. So the separation anxiety or the covert anxiety of the children, or maybe if they are cases with ADHD combined presentation, if they have affective dysregulation, this might be causing some, this imbalance between the sympathetic nervous system and parasympathetic nervous system tone. So when they have the GABA hyperactivity, and when they have the low vagal tone, based on this, they might have less threshold for having a micturition at nighttime. But one of the other reasons is that they don't empty bladder before going to bed. They don't follow the ABCs, and based on that, they are taking a lot of fluids at the evening hours. The other thing might be because of obstructive sleep apnea. If they're snoring and they have low level of atrial natriuretic peptide, and based on this, they would be having more tendency towards having accumulated urine, and they need to empty the bladder when they're asleep. And one last thing could be lack of vasopressin, enough vasopressin, or oxytocin. That is kind of endocrine problem. So in such instances, we might be prescribing some intranasal vasopressin or ADVP, if I'm not mistaken. And the other thing is, in some children, the depression, anxiety, or some kind of behavioral issues, apart from the antidepressant and mood regulatory effect of imipramine, imipramine has been considered as a drug of choice for the kind of neurobehavioral sources for like enuresis. And we need to consider if there's a problem maybe they have some other issues, some organic physical issues in their urinary tract or in their genital organ. They might be having some issues like hypospadiasis. They might be having issues with the anatomy of their urethra or the stuff like that. They might be having infection like UTI, and that might be a reason. And they have repetitive or intermittent UTI, and that's why, especially in girls, that's why they undergo this kind of a problem or urges for emptying the bladder while they're asleep.
May I interrupt, ask one question for the Dr. Namian panel. I would like to know what is the difference between a sleep pattern of ADHD autistic children with normal children. We see many children with adenoid hypertrophy, they have ADHD. And frequently mothers are asking about sleep patterns. Could you please elaborate on this on panel also? Because we see frequently.
Yeah,
Please, anyone.
if I may start, and then we'll seek advice from other panelists to help every one of us, including me, understand more. What I see in my practice over the humble 17 years of work in sleep disorders, both in adult and children, I've seen that many children with autism and ADHD, that they are labeled as autism and ADHD, they might be having some degrees of sleep-related predicaments. They might be having issue with initiating or maintaining their sleep, or they have disintegrity in the macrostructure and microstructure of sleep. They have hyperarousability or the scattered, quite abundant microarousals in their sleep. And that is primarily rooting in the GABA system hyperactivity in them. In the GABA system and the imbalance between the sympathetic and GABA tone, and also the vagal tone, they have this arousal, and the microarousals will disrupt the microstructure of the sleep. That's why they have some rapid stage transition. So the sleep function would not be there. And we all appreciate the fact that the sleep is very important function to clear off the brain from the waste material and inflammatory mediators. If it's not there, how can we expect that a poor sleep is not going to lead to poor wakefulness? So in the wakeful hours, they will be agitated, restless, they will be having breakdowns and tantrums, and they will be having this oppositional behavior and this and that. Based on this, when I don't have enough time to evaluate and go for all those in-depth questions, when I see a child brought to the clinic with agitation, restlessness, and this and that, I say, look at, all right, it's an irritable child with this and that, and I don't see anything significant. This is ADHD. And then I treat the child, as I explained, as I shared, many children are being falsely treated with the ADHD medication, while their problem roots in sleep insufficiency. When the sleep problem is taken care of, then their attention, focus, and behavioral organization is going to be back on track. And they are also wrongly labeled as LD, or learning disability at school. But when the problem with sleep is appropriately touched on, they are going to be back on track in terms of their learning capacity. And one of the things that has been also approved not a long time ago is the use of adrenergic antagonists. So for example, alpha-2 receptor antagonists, including Clonidine. This is a medication for the sleep issues with children with ADHD, and if the primary problem is ADHD or autism, and based on that, secondarily they have problem with integrity of their sleep, then Clonidine is like an alpha-2 antagonist. It's going to help better sustainability of sleep staging. They will have better distribution of the macrostructure of sleep, and we'll be having less of the vasos and less of the arousal instability. So for those children, the use of medications, including melatonin and Clonidine, is going to be hopefully efficacious in many instances, and that's been outlined in the guidelines as well. But I don't know why, unfortunately, Clonidine is very hard to find in the UAE. It cannot be found easily. Some very, very few hospital pharmacies, they have Clonidine. But if you want to prescribe Clonidine for the mitigation of the agitation and also restlessness in children with autism and ADHD, you cannot find it easily. But anyway, behavioral management would be first and foremost approach. If it does not work, medication therapy, including melatonin and clonidine, could be of value. What do you think?
Yeah, so just to kind of add on there, so that was very comprehensive. Children with autism, they have a lot of sensory processing disorders as well, and you know, you
Can
just
you
don't
speak
know
louder,
what.
please, Dr. Omi? Little louder. Your voice is
So
maybe
I was saying,
I'm old, I'm not hearing.
sorry, okay. I was just saying that these children can have a lot of sensory processing disorders as well. And you just don't know, the texture of the pillow might not be right, the texture of the bed sheet might not be right. And something like that can be irritating them and they might not sleep. If they have real autism, you know, and that's what I'm talking about. But when you're talking about ADHD, as Dr. Nathan said, that many of these children can be actually labeled wrong as ADHD as well. And they might have as simple as obstructive sleep apnea, and they are not getting enough good quality of sleep. Although parent might think that they are having a good amount of sleep, duration of sleep, but the quality might be poor. Their sleep arousal may be there, and they just have OSA. You improve the OSA by treatment for obstructive sleep apnea should be treated, and that could be medical management, conservative management, or you know, surgical treatment. And you might see that their sleep has improved and ADHD was a wrong diagnosis or wrong label. So I always say and recommend to our psychologists and child psychiatrists as well that if they are not convinced, as you know, for ADHD and autism, we have so many comprehensive questionnaires from school, from family, and if it's not fitting into the pattern, and they always screen for sleep as well, they should have a very low threshold to be screened by a sleep specialist. If you are labeling children with ADHD, we need to make sure that this quality of sleep is good. So that's another thing. And finally, you mentioned about clonidine and melatonin. So as we know, the role of melatonin is very limited in majority of sleep-related problems. I primarily use for children who are not, you know, children with cerebral palsy, for example, children who are not able to sleep and their sleep cycle is disturbed. The problem with melatonin is that it's a good initiator, but it does not maintain the sleep. So it can help you to fall asleep, but then you'll be awake at 12, midnight, 1 o'clock, and then they can't fall back asleep again.
It's like what you
So-
stated, Dr. Omi, it's a chronotherapeutic. It's not a hypnotic medication. It's a
Correct,
chronotherapeutic.
correct. But in children with autism, we do have a prolonged sustained release melatonin, which is licensed, which is called as Celento, and that can be used. So it's a slow release, it's released all over through the night, and that can be useful. So I would only use, its license is particularly for children with autism. So if you can get that, that will be useful. So that's what I wanted to add.
And just adding
Thank
to
you.
what you very comprehensively stated, and thank you for that. One other thing is the pain syndrome. Some children with spastic, let's say, cerebral palsy, they might be having this spastic posture, and when they are in bed, they need to have a specific bed and mattress arrangement, or they might be having some wedges or something below their limbs to just put them on ease. Because some of them are not verbal, some of them are not going to be able to wake up and say, "Oh, I have pain." They keep sleeping with that pain, and that's why sleep is very shallow, it's very fragile, it's broken. And that's why during the day, they are taken to the physical therapy, occupation therapy, speech language therapy, this and that, and it doesn't work. The reason is that they have dysfunctional sleep, and how can we expect that they can have functional wakeful hours?
Dr. Majid?
Sorry, could you repeat that question? It just cutting off at the end.
No question. We just wanted your comment around this.
Regarding the ADHD and sleep in general, yeah. So with ADHD, I mean, first and foremost, I think we have to rule out obstructive sleep apnea. The other thing is we tend to see parents sometimes using stimulant medication very late during the day, which can affect their sleep. So people are not really cognizant of that. So that's important. The other thing is I always tell parents with our children with autism and or ADHD is that routine is very important for those children. Those children love routine. And whether you're traveling or you're living in two different households, that's probably one of the most important things. So visual cues are very important for those children. They respond to them very well. And then it comes to medication. I think, melatonin, children with autism are very sensitive to melatonin. Small doses can be very helpful. And, timing them is very important. Sustained release is something that is really life-changing for those patients. And I think clonidine, to answer that question, is available in Jalila. I'm thinking it's available a lot mostly with neurologists, and is licensed mainly for ADHD children. I don't feel comfortable using it very much, but sometimes with very severe cases that are refractory to treatment and even melatonin, sometimes it's worth a try, and it really makes a huge difference for the family, especially the ones who have multiple children with neurophysiological difficulties.
Yeah. And when we are talking about clonidine, just wanted to mention that, like, generally as pulmonologists and sleep physicians, we don't like to prescribe. We tend to get our neurologists involved in there. But if one of the other indications of using clonidine could be in parasomnias, one of the questions was about bruxism, and some of these children can have really bad parasomnias when they can become like wake up and they're very abusive. They can have really disruptive sleep, which wakes up everybody, and behavioral modifications are not working because that this could be transient. They can grow out of it, but some children, particularly if they have autism and they are having some of these parasomnias, then clonidine is one of the licensed medicine which works really effectively.
And to add to that, I think since we're talking about both melatonin and clonidine, we have to be aware of the side effects of both. So sometimes melatonin or clonidine can backfire and make sleeping a bit worse. With melatonin, it can be the neurological side effects, or maybe that disturbed sleep, or clonidine becoming very thirsty. These are things that parents should know about. And then withdrawing that medication just on its own can help with sleep consolidation.
Dr. Nami, what you can tell us about sleep paralysis, and is it danger?
Well, sleep paralysis or incubus is, again, another type of parasomnias. And patients wake up when they feel that something wrong is going around them, and they have been dreaming about something horrible. And they wake up at a level that they have, it happens during the N3 or the deep sleep. So it's a non-REM parasomnia. When they wake up, they might be having issues with complete loss of muscle tone. They want to cry, they want to shout, they cannot because they have paralysis of the larynx. And also, they would be having issue with moving around. But at the same time, they feel that something like a demon is approaching them, is sitting on their chest, and they have choking, and they have restlessness. They have issue with shortness of breath, as if they are dying, but they cannot do anything. It is very scary for them, and it might be at some level, when it's repetitive, it's very disturbing. And when the patient wakes up in the morning, they might be having continuous dysphoria, or having this poor mood control and stuff because of that. This is not necessarily going to be something as dangerous, but we need to always consider the overlap between non-REM parasomnias and sleep epilepsy, because there are a range of sleep epileptic presentations that they can overlap, they can mimic sleep paralysis. The person comes and says, I repeatedly experienced the sleep paralysis, but when we do those sleep tests, and we do the brain mapping during the test, and the comprehensive EEG, like high density montage EEG, sometimes it is needed to be done, we realize that the person has a temporal lobe epilepsy. And the temporal lobe epilepsy, although it is not very common to occur during non-REM sleep, but it happens. And then an antidepressant and anti-epileptic medication is going to resolve the situation. One other thing, on the other hand, is the REM without atonia. The children and adults need to normally undergo complete muscular paralysis during the REM sleep, which is a natural, normal phenomenon. And we need to have complete paralysis of our body because the muscles need to get rested. They need to get refurbished and get cleared off from the inflammatory mediators. And some people have REM without atonia, rapid eye movement sleep without atonia. They might be having some abnormal behaviors. Sometimes they're acting out their dream. This could be dangerous because the person might be acting out in a way that is going to harm himself or the bed partner. The children might be getting off the bed. They might be walking. They might be doing something. Okay, it could be REM without atonia or REM behavioral disorder, or it could be non-REM parasomnia, again, which we call it somnambulism or sleepwalking. And they might be going to the staircase. They might fall off and injure themselves to very, very serious level. So we always need to be cognizant about the possible hazards that would, kind of put those cases into challenging situation. And we need to take security measures and safety measures for those case scenarios, to close the doors, lock the doors, and do not put sharp objects in the vicinity. So this is going to help to prevent any surprise for REM without atonia and sleep paralysis and non-REM parasomnia.
And we also need to rule out, like, make sure that we are not dealing with narcolepsy over here. So we do need a full polysomnogram and probably MSLT just to ensure that there is no narcolepsy, because as you said, the sleep paralysis is benign. We just need safety measures. Majority of times you don't need treatment, but if you have narcolepsy, they would need treatment and proper intervention.
And I remember I had a case with narcolepsy a couple of years ago. Unfortunately, he had a cataplectic narcoleptic attack while he was crossing the street, and there was a car crash, and the car had an accident with him, and he was severely injured. And we were asking the driver what happened. He was saying that he was just passing the street. All of a sudden, he fell off, he collapsed in the street, and he was just on his knees, and then he started to fall asleep, like at the middle of the road, right? So this is something which can happen, and it happens in a couple of seconds. When the cataplexy narcolepsy is severe, it can cost the life for the patient. So this is also need to be considered. Thank you for bringing narcolepsy up, Dr. Homi.
Yeah, and sorry, Dr. Majid, you were going to say something. I interrupted. My apologies.
I was going to say narcolepsy, but you were there first.
Similar thought process for pulmonology.
Yeah, but most of the time it's nothing to worry about, right? So and you tend to see sleep paralysis more when you're more fatigued than you're sleep deprived. So I think just I think one of the main take-home messages for us all is sleep duration, sleep hygiene, and bedtime routines and consistency for kids. If we practice those, there'll probably be less patients that we're seeing at the clinic.
True.
And also sleep awareness, Dr. Omi and Dr. Diary and Dr. Majid, Dr. Sora. Please, let's go hand in hand for raising awareness of sleep-related problems at a public level. So having some sleep conferences in Dubai, I'm not aware if there has been recent sleep conferences here in Dubai, and to have to provide the platform to share the research highlights from researchers in Dubai, in the UAE, and in the region. That would be very worthwhile. And also having some public related events to open the eyes of the public to the significance of sleep as the key pillar. And for me, as a brain health practitioner and neuroscientist, I would say sleep is of the brain, for the brain, and by the brain. But of course, the sleep is of the body, for the body, and by the body. And people don't know about that. Still, some people are proud of themselves or their family members when they snore loudly. They will say, good for him or her. They are having a very deep sleep. That's nice. A very sweet sleep, but it's not that. It's a tragedy. And the bad thing is that almost 20 to 25% of the general population in countries like UAE, they're suffering from some levels of sleep-related problems. And in children, no exception. Now, we need to raise awareness about this important thing, because almost every single organ system in the body has something to do with sleep. And we all know that lack of proper sleep is very strongly related to the increased risk of neurodevelopmental problems, to the increased risk of heart problem, lung problem, and also they might be having obesity, diabetes, certain types of cancer. For the elderly, we have increased risk of dementia and this and that. It's huge, and stroke and heart attack. So we need to know that people still got to be more aware. If we as practitioners, experts, and scientists do not capitalize on this, how people can have an access to some source of information? Because not everyone go to reliable, valid sources of information online to read about this. But if some people like yourselves will come to the podium and help the people understand about this. I had a chance to go to the Dubai Eye Radio a couple of times over the past 2 months, talking about sleep and memory and everything. These are, I mean, these are very. I was feeling blessed about this opportunity because many people can hear us, can hear me, hear you, and by this one single point may change a person's life and approach to mental health and bodily health and sleep health.
I always teach medical students, and one of the videos I always ask them to watch is a 16-minute TED Talk by Matt Walker. It's called "Sleep is Your Superpower." You must know him. He's a sleep scientist now based in California. He's a British scientist, and that kind of pretty much no one has ever said. Majority of people will just say it has changed my life. It has changed things, because that's what I teach and preach for everyone. But he's much more eloquent than I am, and he puts it very nicely. And that's a very so everyone who is listening this webinar, who is participating, I would strongly recommend that tomorrow, when you are having, just a relaxed 15 minutes on Saturday, please do watch it. Sleep is Your Superpower by Matt Walker. Even if you learn one thing from that, that will be helpful, and you can propagate that for your family, for your people around you, and that will help. And that's how the education comes in.
Matthew Walker is great, yet this does not undermine our responsibility to raise awareness. How about that?
No, absolutely. I completely get it.
I know that there are many people in the UAE who would listen to you than any other people, right? So we need to do this together, Dr. Momin. Thank you for taking this into account as well. And Dr. Majid and Dr. Diari and Dr. Sahab, thank you for this.
So I think this is a good start. Like, this is a very good platform. We're engaging with a variety of specialties and people of from different healthcare backgrounds. And just to add to that, we have an annual sleep meeting that happens every year. This is chaired by Dr. Mohammed Al-Fawqani from the University. And I think it's in its maybe third or fourth year in a row. Last one was in Abu Dhabi, and they do alternate between Abu Dhabi and Dubai. So that's something for whoever is interested. And yes, I think we have to engage more with the community. Now that we get to know each other, we probably can do that.
In 1 month, Dr. Majid, I guess 20-something of March, we'll be having the World Sleep Day. And that would be a very good start point just to let the people hear more about sleep and its significance.
Correct. So we are having a big kind of event as a public awareness on that World Sleep Day. So it's for general public, just having the sleep commandments, 10 healthy sleep commandments, putting the posters, having some people from the sleep lab and us being there to answer questions, about sleep duration, snoring, and things. So I think that is a good platform to just say that, World Sleep Day, what is it? It's just about awareness.
I really appreciate that attitude. Thank you.
Dr. Zarab?
If there is no further question, it's almost going to be 11. I would like to thank Dr. Nami for excellent presentation, discussion, Dr. Majid, Dr. Omi, Dr. Diari, and Dr. Kalpana couldn't join us. I would like to thank Tawfiq for sponsoring this, and I would like to thank our viewers following us. Thank you very much. And Doctor, if any comment by our panelists, so this was a very good point that to raise the awareness, to have a platform on maybe on International Sleep Day. So to the first conference to be on that, Dubai Pediatric Club is also always ready to join you. So Dr. Diari, any one of the panelists, the final remarks, please.
The speaker.
Yeah, you know what I'm going to say. I just want to extend my really deep appreciation and acknowledgement for this deep-rooted DPC. I've been going through the pages and also the legacy of DPC. And when I found out that I've been given and accorded this opportunity to be sharing some little insights with the audience of DPC, I was deeply moved. And I would like to thank you again for this opportunity.
Thank you very much.
Thank you.
Thank you. Thank you, Dr. Majid. Thank you, Dr. Amin. Thank you, Dr.
Thank
Zoran.
you.
Thank you very much and good night. Thank
Thank
you.
you. Thank you, everyone.
See you soon.
Bye-bye.
Sleep well,
Good
huh?
night.
Bye.
Thank
Sleep
you.
well.